Today is antidepressant efficacy. The topic of antidepressants was suggested for this year's didactic curriculum, but it was really too big to have in one presentation. So this is kind of part two of the antidepressant presentation. So just two objectives for today: to describe the efficacy endpoints from clinical trials related to antidepressants and to compare the efficacy data of antidepressants. In recognizing, when I first started looking at this, trying to evaluate and pull in all of the efficacy data right from the ground up, it was a little bit daunting. So what I decided to do for this was to focus on the STAR-D data. So that's going to be most of the information that we talk about, likely because the patients that you're encountering with depression likely will go through a similar progression. So I think that might be the most useful in a clinical realm approach to this. So that was what I did. Hopefully it'll be useful. But before I go there, I found this study and it kind of blew my mind a little bit, so I wanted to make sure I included it. Looking at antidepressants, I wanted to look at how frequently are we using antidepressants. And one of the ways that you would look at that is how prevalent is depression in the United States. Well, recently there was an article published in the JAMA Open Network, and it looked at, so it was a survey. They had done a survey of the patient health questionnaire, the PHQ-9, so just a depression screening in over 5,000 patients before COVID hit. After the pandemic and things were shut down in March, they went back and evaluated in a survey more than 1,400 additional individuals. And they published their results. So they looked at their PHQ-9 score and they gave it the four categories. So their mild scores were 5 to 9, moderate was 10 to 14, moderate severe was 15 to 19, and anything 20 and above was considered severe. Strikingly, as you can see, so those blue bars were the pre-COVID levels. So really that 5 to 10% of patients being more moderate or above, more consistent with what we would expect in the general population. They've seen a tripling in the depression. This isn't include anxiety symptoms, but a tripling in the depression symptoms that are reported. And this was just adult outpatients, so not those that necessarily were in any type of mental health care previously. So mild symptoms reported in a quarter of those patients, moderate symptoms in almost 15%, moderate to severe symptoms in almost 8%, and severe symptoms in over 5% of the respondents. So that really caught me off guard a little bit. I think there's a lot of, I had done some literature searching on the impact of the pandemic on alcohol use for my alcohol use disorder lecture. And that's gone up quite a bit, where individuals were reporting drinking on average over 6 days a week. Not always binge drinking, but definitely having an alcoholic beverage more than 6 days a week. In some cases it was due to boredom, some cases it was as a coping strategy, but I think this really speaks to an increase in the needs that if we don't see now, we are likely to see in the very not so distant future. So with that context in mind, this was the chart that's on the right-hand side of this slide is data from the National Center for Health Statistics. So this was the survey over 2015 to 2018, and it had remained relatively consistent, where we see about 10 to 25% of patients are taking antidepressants, and that could be for indications well beyond just depression. But seeing that number, it's very likely that that number will climb. So keeping that in mind, how can we figure out, with all of the antidepressants that are available, what's the most effective? These are the ones that are available in the US. I put in asterisks next to ketamine because it's there for completion's sake. The pharmacist in me couldn't leave it out, but we're not really going to focus on that one today. So how do they measure up? There's a number of different efficacy endpoints. The ones that we'll focus on that were included in the literature are rating scale scores. So specifically the Hamilton Depression Rating Scale and the Quick Inventory of Depressive Symptomatology. So those are the two main ones that were used in the STAR-D trial. Obviously things like clinical global impression, so how much patients look like they're improving their overall quality of life and productivity is also important, but adherence, their ability to complete the trial, to maintain their treatment long-term can be really important, and that also will be included in one of the literatures that I cite a little bit later. So on to the data. So the STAR-D trial, so sequence treatment alternatives to relieve depression, STAR-D. So I keep saying so, I will try not to do that. It struck me when I pulled this data that I didn't realize that it is a bit dated, but I think it's still really important and helps shape what our approach to depression is. Just as a refresher, this was a multi-site, prospective, multi-step clinical trial. So it was a nationwide study that was done in adult outpatients that had non-psychotic major depressive disorder. They had over 4,000 patients, and what they wanted to do was patients that had not repeatedly failed other treatments, what's the best progression? We have all of these options. What would be the best way to treat these patients? So it started with level 1, and then if patients couldn't tolerate or didn't respond, then they could progress to the other levels. And I do have, so I wrote this out because here are what the other levels are. So couldn't tolerate or didn't respond to citalopram, we could switch or augment. If those didn't work, then we could switch to other agents or also augment. And then if that didn't work, then we were kind of scrapping those treatments and switching to either a monoamine oxidase inhibitor, one of our older agents that's a little trickier to use because we do have to watch the diet, or a combination of mirtazapine and venlafaxine. And I thought that looked nice, but Dr. Paxos that I work with had the flow chart, which looks way better. So I included this as well. So a whole bunch of different options. So in looking at our selective serotonin reuptake inhibitors, and then including a number of medications that work differently. So is it better to switch to something else, and how do these compare? Overall, in the acute short term, so the 12 weeks of treatment, at least in the first couple levels, level 1 and level 2, and this also was Dr. Paxos's slide, so thank you to him for allowing me to borrow this. That saved me a ton of time trying to make it look pretty. So step 1, level 1, we saw about 28% of patients did go into remission. So essentially the scores on their depression rating scale were low enough where there were very few symptoms or no symptoms whatsoever. If they needed to augment, so maybe they couldn't tolerate the citalopram or that one didn't work for them, so we added something else on board. The buspirone and the bupropion, so buspirone usually used for anxiety, and bupropion, if we added those on board, then we saw about 30% of those patients achieve remission, so their symptoms were essentially gone. If we needed to switch to something else, the venlafaxine, we saw about 25%, and then right around 20, little over for bupropion, little under for sertraline. So in general, we saw about a 20 to 30% remission rate for these level 1 and level 2 patients. That doesn't include the cognitive therapy patients, I acknowledge that, but generally we were seeing pretty consistent results. You could suggest that with the sertraline, maybe if they didn't respond to the citalopram, that may not be our best option to go to because the remission rates were a little bit lower. But when we looked at those three, I lost my pointer, those 3 interventions together, there wasn't a statistically significant difference between those percentages. So about the same number of patients were likely to respond. So early in treatment, it looks like we could try a whole bunch of different things. So thinking about those other factors, other meds that patients are on, what other conditions they have, that may, what their insurance is, that may play a bigger role in which one we pick. For some of the later stages, you'll see that we start to see lowering of the efficacy. So if we're going to level 3, where we have the thyroid replacement and the lithium that are added on board, we still are 15 to 25%. So we're kind of in the ballpark, but we're starting to see less responsiveness. That makes it a little muddy, as does if we had to switch to either nortriptyline, one of our older agents, a tricyclic, or mirtazapine, which had the 12% remission rates. It's not really clear that that's due to the medicine not being effective or a patient being so treatment resistant that they're not responding to the pharmacotherapy in general. So I do kind of, as we move to the right side of that slide, I just do want to put a little star on there. We do see the numbers go down, but it may not mean that they're less effective, just that may be a much more difficult patient population to treat. So if mirtazapine looks to be a good fit for the patient that's in front of you, this should not deter you from doing so. And I'll try to convince you of that a little later. I included these because, and you're going to get all of the slides, but I just wanted to draw your attention. There's a ton of information here, but time. I really would like you to think about the time element to both response and remission. So this one includes step 1 and step 2, both the switching and the augmentation. So the second and third columns are those rating scale scores when they first started and at the end of those 12 weeks. The number of patients that responded, so in this case, the response was a 50% reduction in their score. So if they showed a pretty significant improvement, how many of them did so? And you'll see, again, we're looking 20, 30, a little more than 30% in the second step and almost 50% in the first step. So quite a few patients are responding to treatment. And it took between about 5 and 8 weeks to respond. So making sure that we're setting the patient up to be successful. If this is going to help you, it may take some time. You may need to be on this for a month or 2 before we can really tell if it's helping you or not. Abandonment of antidepressant prescriptions is incredibly common, where patients just stop taking it because I felt better and now I don't need it, or I didn't think it was working at all after a week and a half. And the side effects can be really bad initially, especially with some of the SSRIs or SNRIs, your venlafaxine, your sertraline, things like that. So we definitely want to make sure we set them up to be successful because the medicines do work. The next column is weeks to remission. So interestingly, in some cases, the patients who are going to respond and get rid of their symptoms may do so faster than the patients who just respond. So if we're starting to see that patients' symptoms are improving significantly, that may mean this is the best agent for them. Just because they're not improving really quickly may make us think, okay, we need to see if the patient's getting better and maybe think about being a little bit more aggressive, either augmenting or switching. And then as you can see, the intolerance rate, there is quite a bit of that goes along with treatment of depression. For the next level, looking at if we needed to switch to other things. So the top ones, we actually added bupropion or venlafaxine to those patients that were initially switched to cognitive therapy. And we see similar, so our response rates are a little bit lower. The time to response takes a little bit longer. Now this was step 3. So again, maybe not so much that the medicines didn't work, but as we get farther down and the longer it takes us to get control of those symptoms, the less likely we are to be able to get full control. And also true, and this is the last steps. So augmentation is the end of step 3 and then step 4. So those last couple rows there at the bottom, and if you can't see it here, you will get a copy of the slides, but they really took 7, 8, 9 weeks to be able to see a response. And our response rates were more in the mid to upper teens, as opposed to being in that 30%. So one thing that I would like you to think about is the efficacy of our medicines really is going to depend on how responsive the patient's been and how long they've had their symptoms. the longer they go untreated, then maybe the longer it's going to take us to help get those back under control. One caveat I do want to say, there was a meta-analysis that was published that looked at antidepressant use, psychotherapy, and then the combination of the two. Most of these were agents that were mainly just antidepressants, pharmacologic treatment, easy for me to say. But adding other treatments on board, especially therapy, can be more beneficial and improves the response and the remission rates, especially those long-term remission rates, because likely some of the external confounders that may be increasing those depression symptoms aren't going to be going away anytime soon. Long-term, what does this look like? So as I mentioned, as we get to those higher steps, the likelihood of relapse, so it was harder to get response or remission, and the likelihood of relapse went up as well. So you can see in the graph, those lines that go down, it's the percentage of people without relapse, and it decreased over time over the course of their year-long follow-up. So those that required step 3 or step 4, we saw them end up with about 50% of them had relapsed, even though they stayed on treatment before the 6-month mark. So really trying to be a little bit more assertive in getting some of those wraparound services, encouraging those lifestyle changes to really help bolster and preserve that response that we get to the medications. So taking a step back, that was a little bit older data, and it didn't include all of our antidepressants. So what do some of our other antidepressants look like more head-to-head? So this was a meta-analysis that was published a little while ago, but still a little bit more recent than STAR-D. It was 117 antidepressant trials for patients with major depressive disorder that were adults. Their primary outcome was the percentage of patients who responded. So again, that 50% reduction, regardless of which rating scale they used. And then the percent of patients who dropped out of treatment. What they found is that there were some differences. So they found that citalopram outperformed paroxetine. Escitalopram outperformed citalopram, which is interesting because they're very closely related. Mirtazapine outperformed both fluoxetine and venlafaxine. So if you remember back in STAR-D, it looked like it was 12% remission rate at 12 weeks. This suggests that, you know, if we're using that early on, we're probably not going to see a 12% remission rate. It might be equal to what we see with the other medications, or superior to a couple of these. Sertraline or Zoloft outperformed the fluoxetine, and venlafaxine outperformed fluoxetine. So these are the odds ratios, so the likelihood that it's superior to the other agent. So 1 would mean that they're equal. So as you can see, they're above 1, but they're not significantly above 1. So yep, they're better, but it's definitely marginally better. Overall tolerability, most of them were equally well tolerated. They all had adverse effects and some complaints from patients. One more thing I just wanted to add. So there's a couple different meta-analysis that looked at tricyclics versus, which are an older class of medicines, versus the serotonin reuptake inhibitors, one of the newer classes. There was no difference in efficacy between the two. Tolerability really was the driver. Patients didn't like the side effects of some of those other medicines like the amitriptyline, but they still work. So you may have situations where that might be appropriate for your patient. And the same with the other class. So the monoamine oxidase inhibitors, we tend not to use those because we have to be careful with diet with those medicines, but they're equally effective for the treatment of depression with the other antidepressants, but they may be superior to some of the other classes of medicines in those patients that are harder to treat. So as I said, as you get to level 3, level 4, the tranylcypromine was one of the medicines that we used in step 4. That's a monoamine oxidase inhibitor. There's a couple other agents in that class that may outperform some of our other antidepressants. So that's a class to definitely keep in mind if we get patients who haven't responded to other things. So the good news is we really can get success in about 2/3 of our patients with pharmacotherapy. There are some slight efficacy differences, but we have to keep in mind those other factors, comorbidities, other medicines, as well as how well they can tolerate it. appropriate dosing and close follow-up to try to make sure that we're keeping a patient on the medicine long enough to see if there's a benefit, and being a little bit more aggressive to help get those symptoms under control can really do the best to get the maximum outcome from these medications. That